Mitzi, I think you're on the list?
I don't think so.
No.
Not this year.
I'm on the list, so. Mary Lou Galantino is definitely a woman who needs no introduction. If you just go to Google and Google her, you'll find out all the incredible work she's done in the area of research. Just the tremendous progress she's made for the profession of physical therapy and complementary medicine. And you can even find her on a TED Talk where she will discuss her personal journey. But today she's here to talk to us about oncology rehab, and I think it's just tipping the iceberg of information and directions that we hope to go as an organization.
Well, thank you all so very much. I'm particularly grateful to be here. I feel like we are neighbors in a way beyond measure. I feel like it's a reunion for my former students who are now employed by BACRAC. I feel my long-standing friends from the moment I arrived to Stockton in 1991. And indeed, I am grateful for the opportunity to really have us all as a rehab team. And so I want to speak not just from the physical therapy perspective, but really the whole embodiment of cancer rehabilitation. I really want to say a special hello to all of our associated clinics that are joining right now. I'm particularly thankful that we have our technology gurus here in the room to make this happen. And indeed, it is this very first case that is targeted to our outpatient clinics in a way to think about screening and thinking about the way we create the algorithms when looking at patients or potential patients with an underlying cancer diagnosis. So again, thank you so much for this opportunity. And for our very short time that we have together, I'd like to make sure we have some time to answer questions. I would like to have us think about what is evidence-based cancer rehabilitation. And I remember my training at MD Anderson University of Texas Cancer System, where I had the good fortune in the early to mid 80s to train with a top cancer system, and there was only about 10 of us in the department. Right now, the rehab team is comprised of over 320 healthcare rehab specialists within the MD Anderson system. So cancer rehabilitation from the early 1980s till now has certainly exponentiated, and I'm thrilled about that because not only are we growing as a profession, but our oncology section of the APTA has driven much of the research agenda, and I've had the good fortune for over a decade to serve on the research board as the chair of the oncology section's agenda and where we move forward in establishing some of these outcome measures. So outcome measures will be sort of dipping our toe in the waters of that, because as we begin to look at what are those optimal outcome measures, and as we begin to coalesce the benefits that we embrace within a rehab trajectory, using valid and reliable outcome measures will also be a way to articulate the great work that we are evolving into here. So oncology rehabilitation is our entire team. It includes speech therapy, occupational therapy, physical therapy. We cannot live without social workers and psychologists on the team. We have a whole host of individuals that really make our team really putting the pieces back together again. To give you a little bit about some of the epidemiology, we really see that indeed individuals here in the United States, we have new cancers in the millions. But indeed, when we look at from pediatrics to geriatrics, we really do see that not only are we increasing survivorship and less individuals are now dying of a cancer diagnosis, but we have the many, many impairments and comorbidities that exist from the side effects. So the cancer survivorship trajectory is significant to address in the context of this increasing survivorship statistic. So we know all of the underpinnings, of course, to the pathology. We know that it is cancer cells gone awry. We also know that the underpinnings of the immune system are such that those natural killer cells have maybe not been as robust enough to keep a cancer cell in check, and thus the situation emerges. And then add to the complexity those of us who have a genetic predisposition to a cancer diagnosis as well. Thus, in our history taking, the importance of capturing those data as well. In addition to that, there is a correlation that the World Health Organization found between decreased physical activity rate and increased cancer mortality. We are best poised as rehabilitation therapist specialists to be advocating in the community for those individuals who have finished treatment. Cardiac rehab for individuals that indeed have been 10 to 20 years out after exposure of adriamycin that may present with cardiomyopathy is another reason why we need to be screening patients and then implementing an incredible cardiac rehab program when appropriate. Also, for the many surgeries and the radiation and chemotherapy, we'll be talking a little bit about that as well. And then how many of you have engaged in any survivorship plans with patients? That could be an entire hour that we could talk in and of itself, because the Commission on Cancer actually mandates that if you are a certified cancer center, we must be developing cancer survivorship programs such that they are done in concert with the patient and the entire team. Ultimately, for long-term survivors, they go back to their PCP, and then suddenly this sort of security arena of having the team may or may not be there. And thus the survivorship plan is that articulated document that is the sustainable plan going forward. What we know to be true is that sedentariness and elevated BMI are risk factors for recurrence. Many of our patients don't realize that, and they don't realize the essential nature of physical activity. And thus that second recurrence can be a bit challenging, and indeed that sedentariness adds to the complexity. This is a stark statistic. 65 to 90% of individuals who survive cancer will develop impairments. The question is, are we targeting all those individuals within the scope of our practice as well as in the community? And so we really can make a huge difference in terms of addressing some of these impairments, and more so actually asking the questions that patients may think, well, I'm just supposed to live with this severe pain in my feet and my hands from neuropathy. No, not living with it. You've survived cancer. Let's talk about mitigating some of these impairments to have you feel better in your body. And that's what we do so well as a rehab team. So all of these components are necessary, really looking at a full system assessment, looking at some of the side effects from treatment, appropriating the support mechanisms with psychosocial needs, and then adapt the exercise regimen, and as I've mentioned, the survivorship plan of care. So if we think about our trajectory and what's really possible, as I'm truly thrilled that we are, I see us as a center of excellence, as a cancer rehabilitation focus for all of Southern New Jersey. I mean, I already have the vision that Backrack and all of our satellite sites will be the ones to make a difference in those survivors here in our region. And we could play a role in any of these domains, from preventative to restorative to supportive and to palliative. And the gift that we have is that we are such a strong team in a way that really ignites the challenges of the interprofessional component in a way that we are moving through that trajectory that is key. So I'd like to start out with this patient case. And I'd like to start out with this patient case because it gives us an opportunity to reflect on the very notion that back in the day when I was in Texas and I had a private practice, and we were all attempting to get autonomous practice. The one statement that physicians said, the reason why we did not have direct access was because we were unable to diagnose a patient with cancer. That was the #1 reason. So what we have done since that, and now that we have direct access in most all states, indeed, we have upscaled the art of understanding the differential diagnosis, even within the context of our outpatient orthopedic cases. And so let's take a look at Jack, who's a 34-year-old male, presents to his PCP for a checkup, has left shoulder pain, fatigue, swelling of the left eye, and a bump on his finger. He was new to the practice, newly married, by the way, as well, and so the PCP recommended the following: brain CT, consult to ophthalmology, sonogram of the finger, blood panels to really look at lipid screen, and then referred to us in outpatient physical therapy. So after a PT evaluation, the therapist actually noted that there was an insidious onset of left shoulder pain with pain at night, one of our red flags. Pain was 6 out of 10, and worse when lying prone with the head turned to the right. So we got some very specific positions of worse pain at night. There were no imaging studies available, and it did not reveal rotator cuff impingement, but there was some decreased pain with manual cervical traction, and so Jack returned for 5 visits. Okay, so we did do cervical traction, gentle shoulder and strengthening and range of motion exercises. And then there was increased pain for some unknown reason, and this was noted by the physical therapist. And then there was complaints of bilateral axillary pain, which obviously wasn't consistent with the original presentation of the orthopedic referral. So what are you thinking? What would you do at this point? Anyone? Thoughts about it?
Just at the PCP and see what this brain CT.
Right, let's get the data, let's get the imaging data outcomes. And certainly we see that the ophthalmologist identified left ptosis and left pupil dilation. Well, he has Horner syndrome. And so then there was immediate imaging, and this is what was found. So what we have here is a Pancoast tumor, which a large mass on the medial aspect, which makes sense. In the prone position, lying prone with the head to the right, was an impingement, essentially, and a space-occupying lesion here that is really a challenge. So we have a mass here, but let's also look at the spine. And let's also consider what is happening with an MRI without contrast. And what we see here is that there are these fracture bursts from the metastatic lesions at C7, T7, and T12. However, there was no cord compression. What's the next step? Obviously, he started to experience upper thigh numbness, weakness, and difficulty with ambulation. And the MRI without contrast showed a pathological burst of T2 vertebral body. So what we have here is now starting the beginning of some cord compression due to the metastasis with metastatic disease from C7 to T4. Thus, he was an emergent surgical patient for fixation, and as you can see here, this is the X-ray of the chest following spinal fusion and the extent of the hardware. So, thoughts about this? This is an outpatient referral with shoulder pain. The red flags indeed were present, and without imaging, it is very difficult for both the PCP and the PT to rule out a musculoskeletal cervical pathology. So obviously the CT of the chest changed the trajectory, and if we really go back, I mean, even though he had reduction of his pain with cervical manual traction, it was essentially contraindicated. Unfortunately, this is a very aggressive tumor, and the patient passed away 8 weeks later. So while this was an upheaval of a situation, the storyline really begins around who are we as we get our orthopedic diagnoses, and how quick are we to triage for further diagnostic workup. So any questions about this case? I just wanted to bring this case for our outpatient satellite colleagues to think about when someone has a primary diagnosis, as Jack did, compared to those individuals that have a previous history of cancer that are coming in for other impairments that may or may not be related to the original cancer diagnosis. And that art of being able to do a full systems review is really key to triage. Any questions? I wish I could say any questions to our satellite folks to hear, but let's think about many of the patients that you've seen with central nervous system involvements. You know, our patients with brain tumors come in very many different with signs and symptoms. Of course, gait alteration is one of the primary considerations, headache, visual changes. And the question that we want to ask, is it benign or is it malignant? People say, how can a tumor be benign? It's all about the location and the grade and the stage of that tumor. And so within that differential diagnosis, we're aiming to find how has that impacted all of the systems involved, from the genitourinary system to the GI to cognition and ultimately sleep alteration. So if we were going to talk about a benign tumor, this is a tumor, the cerebellar pontine angle tumor, which literally sits just in the vermis of the cerebellum, just adjacent to the cerebellum and up against the circle of Willis, and all amidst the cranial nerves. This patient, while it's a tumor that is on the outside of the brain, is pressing in against all those cranial nerves. So what cranial nerves might you think are impaired? Any ideas? Want to throw one out? So right there. So trigeminal could be one, okay? But the first sign and symptom of the acoustic neuroma really is vestibular signs and symptoms, which we see a lot of vestibular patients here, right? And also some hearing issues along with this inability to right oneself to center, okay, because it's right there. The good news, though, as much as this looks a bit ominous, because it's on the superficial surface of the cerebellum, in its totality can be removed, and we're rehabbing these individuals exactly as we would a vestibular patient. So many of the wonderful existing programs that we serve individuals with and through here at our main campus and at our satellite campus is really an application. It's the ability to identify and diagnose that differential diagnosis. Is this a vestibular patient, or indeed are there some underlying pathologies that could be the contributor to that? And then of course, any change in bowel and bladder with respect to those tumors that are primary tumors in the spinal cord, or are they metastatic lesions? What we know about breast cancer and lung cancer is that it tends to metastasize to the spine. Okay, so the question begs, is it primary or is it a secondary metastasis? And unfortunately, we go from benign to metastatic, and with this metastatic tumor, as we know, the glioblastoma is the most aggressive tumor that, unfortunately, one of our senators, John McCain, is suffering from right now. We've lost another senator, Senator Kennedy, and I think it's brought to light the aggressive nature of the tumor, and yet we do debulking of these tumors to improve function, and they really are dependent upon us to foster the quality of life of their remaining days. So from a neuro rehab standpoint, were able to make a huge difference in improving the quality of life, balance, coordination, ADLs, and to the degree to which we can have individuals remain in their place of employment, the art of voc rehab is really key. So in the very basic structure, as we think about all of this, we're thinking about patient factors, their health status, their premorbid comorbidities of other potential systemic diagnoses, and also specifically around the tumor type, the location, the stage, the grade, and the response to sometimes testing to determine the best treatment strategies going forward. That's really where our considerations come into play. When we talk about preventative, we have the classic example of Angelina Jolie, who is our poster woman for talking about doing prophylactic treatment because she has the genetic form of BRCA1/2. So when we talk about the genetic piece, there are preventative strategies, including removal of the ovaries. So that preventative treatment, if there is a genetic component, indeed is an option. So preventative also can mean that we, as a community, talk about the connection between colon cancer and obesity. So we know that many of our patients that are orthopedic knee replacements, hip replacements, many of whom may have an elevated BMI, that their risk of a knee replacement reduces with every 50 pounds of loss, right? Similarly, for our cancer colon survivors, if they have a genetic predisposition and they have elevated adiposity, they actually increase their risk. Both genetic as well as the obesity situation may indeed elevate their risk. So if you have a patient that may indeed be coming in for low back pain and they have GI issues coming along without a diagnosis, you or I might be that patient that we triage into the trajectory of a further differential diagnosis, an SCT of the abdomen, especially if there is that history in the family. But lifestyle alone, fitness and movement are really key in looking at prevention. There's a whole host of literature in that area. With respect to restorative, those of us who have had a primary cancer diagnosis and choose to have a treatment trajectory that leaves us in survivorship mode, that requires oftentimes surgery, sometimes associated radiation, and chemotherapy. So I'm very grateful to say that I am in the restorative category when I was diagnosed. I was a missed diagnosis because I was pregnant, of which I was told that I was indeed, there's no necessary workup, we'll wait till you have the baby, and subsequently there will be a simple mammography. Mammography was negative. I had a mammography right away. I had an ultrasound which was negative. But I was lactating and breastfeeding for an entire year after I palpated what I thought to be was something not normal in my breast tissue. So the restorative part that I love living in here is the fact that I had a lumpectomy, did not get clear margins, needed to do another lumpectomy to get clear margins. And then because we look at the axillary node, so we do sentinel node. If the sentinel node is negative, then you're likely not to have the disruption of the lymph system, which is a very, very essential system within the context of cancer survivors. And so because we found 0.1 millimeter of tumor in 2 locations of the sentinel node, that required axillary node dissection. But I did have a choice, because I had a choice to actually have a mastectomy to avoid radiation, because we'll talk about radiation in just a little bit regarding radiation fibrosis and then the long-term side effects therein. Then we have supportive, of course, those that do have metastatic lesions, and we can radiate, even with metastasis to the spine, we can radiate for the optimum reduction in pain and improvement of function. And then ultimately palliative, which are individuals in not always end stage of life. We can talk, quite an extensive beyond the 6-month limit, and indeed individuals we can serve to improve quality of life even at end stage. Part of my private practice in Houston was establishing home care hospice, and it probably was one of the highlights after my training at MD Anderson that really gave me a window into the spirit of individuals at end stage of life. And so the ability for us to make that difference in anywhere along the trajectory, really, we might be coming in at any one of these domains regarding whether an individual will undergo medical or surgical interventions. So with surgical interventions, what's particularly important is restoration of optimum wound care and return to function. And then ultimately, when we think about 2 orthopedic cases that render individuals also from loss of range of motion and the team coming on board, is the diagnosis of head and neck cancer. How many of you have seen head and neck cancer patients here, right? We have a whole host of them. Good news for head and neck cancer. If indeed it's HPV related, okay, so it's herpes virus, which is the primary driver of some of our head and neck cancer patients, they tend to have a better prognosis. So that's the reason why our patients with head and neck cancers do indeed have longevity. The challenging part about our head and neck patient is, of course, the art of speech, swallowing, nutrition, and this one very crucial nerve that is the most vulnerable nerve. What is that? Anyone know in the audience? Say that again?
Vagus nerve?
Not the vagus nerve, but that would impair the diaphragm, right? Pardon?
I was thinking of trigeminal again.
I like your trigeminal
No, I-
journey here. It's actually the spinal accessory nerve. So elevating the shoulder. So if you have someone that has the primary tumor in the mouth or in the oral cavity removed and has metastasis into the anterior cervical chain, you have individuals that have the vulnerable risk of the spinal accessory nerve that really is key here. And so these nodes are typically removed, and patients will have, it's right here, it's very, very fine, it's the nerve that is the most vulnerable during surgery. And it's prone because of either it's hypoxia or a stretch. The good news is that if individuals have a stretch lesion to this particular nerve, recovery can still be quite optimum. So what we have here is a patient that presents with neck dysfunction, functional inability to lift the shoulder, reach up overhead. And so all of this results in scapular dyskinesis, shoulder and neck pain. And the trajectory is a good one. Yes, it can take several months. In some instances, depending upon the degree of the surgical insult to the spinal accessory nerve, it could take years to recover. So if we look at a couple of pictures here, you can also see some differences between the long thoracic nerve palsy versus spinal accessory nerve palsy. Okay, so you start to see the differences in overall function. This applies to every activity of daily living, dressing, especially your occupations, electricians and construction workers who are working overhead where we need to return them to function. Furthermore, you can see some differential diagnosis as well within other shoulder orthopedic injuries, but most often we need to appreciate not only the surgical impact, but now also if you take a look at this patient, which services would we refer him to? Name a few. speech,
OT.
OT, PT, psych, social support for body image issues. So most of these folks, when they have extensive surgery, will actually have a PEG tube placed in their abdomen to supplement for nutrition. But we really want to return the normal function of the GI system.